How good was ancient medicine, really? Not the herbs, not the chanting. Real surgery. Ancient surgeons cut into skulls, deliberately, and their patients walked away. In 19th century hospitals, the same operation killed more than half the patients. On Borneo, someone amputated a leg inside a cave, and the patient recovered. That was 31,000 years ago. Over 1,000 skulls in Peru alone show trepanation with survival rates above 90%. This isn't folklore. This is data. Let's start where the data is hardest to argue with: Peru. Somewhere between 400 BC and 1500 AD. The Andean highlands, thin air, biting cold, no electricity, no running water. A surgeon, no degree, no operating room, no autoclave, picks up a blade made from volcanic glass, obsidian. When you fracture it along its conchoidal plane, the edge is thinner than the sharpest steel scalpel on the market today. We're talking 3 nanometers. A modern surgical blade, around 30. The ancient tool is 10 times sharper. Electron microscopy confirms it. Obsidian fractures cleaner at the cellular level than surgical steel. Some modern eye surgeons have actually experimented with obsidian blades because the incisions heal faster. The surgeon cuts into the skull, not randomly, with purpose. The techniques varied: scraping, grooving, drilling, each leaving a distinct signature on bone. Researchers have cataloged hundreds of specimens. The variation tells the story. This wasn't one technique copied blindly. It was a living discipline, refined, adapted, taught. Let's look at the numbers. John Verano at Tulane University has spent decades studying Peruvian trepanned skulls. Out of more than 800 specimens, the survival rate in later periods exceeds 90%. 90%! Without gloves, without soap, without a malpractice attorney. How do we know they survived? Healed bone around the opening. The body doesn't regenerate bone around a wound unless the patient lives long enough. Months, sometimes years of regrowth. Many skulls show multiple trepanations, meaning the patient survived the first surgery, came back, and survived the second. Meanwhile, during the American Civil War, 1861 to 1865, the survival rate for the same procedure hovered around 50%. In some field hospitals, it dropped below that. Progress, apparently, is not a straight line. Surgeons with steel instruments, medical degrees, formal training in anatomy, supply chains stretching across a continent, and they lost half their patients to infection. Someone without any of that did it better, consistently, for over 1,000 years. The settled science files this under ritual practice. Ritual. Sure, the most successful ritual in medical history. A ritual that requires knowing exactly how deep to cut, where to stop, how to control bleeding, and how to prevent infection in an era without microscopes or germ theory. Call it ritual if you want. The data describes a discipline. But Verano noticed something else in those skulls, something the textbooks skip. The Peruvian skulls show a learning curve. Early trepanations, dating to around 400 BC, have lower survival rates. By the later Inca period, the technique had been refined to near perfection. No peer review, no journal, just results. This isn't random, it's institutional memory. Someone was teaching. Someone was learning. Someone was keeping track of what worked. In a civilization that left no written surgical manual, the blade explains the cut. But a blade without a protocol is just a wound. Where's the protocol? The step-by-step system that turns a hole in the skull into a survivable procedure. India, around 600 BC. The Ganges Plain. A physician named Sushruta compiles something that shouldn't exist at that point in history. The Sushruta Samhita, a surgical compendium containing over 300 procedures and descriptions of 120 specialized instruments. Not sharpened sticks. This was a toolkit with a table of contents. Instruments designed for specific tasks: cutting, gripping, probing, cauterizing, suturing. Some were made of steel. In the 6th century BC, the anchor procedure, rhinoplasty. A section of forehead skin is measured, cut on 3 sides, folded down over the nose, and stitched into place while still connected to its blood supply at the bridge. The tissue stays alive because the pedicle, the uncut 4th side, keeps feeding it blood. The nose heals. This is not a concept. It's a documented surgical protocol with preoperative assessment, intraoperative steps, and aftercare instructions. British surgeons rediscovered this technique in the 18th century, more than 2,000 years later, after watching Indian surgeons perform it during the colonial period. They called it the Indian method. The name stuck. The procedure is still in use today. 2,000 years, and the best the British Empire could do was copy it. Sushruta also describes cataract surgery, couching, pushing the clouded lens out of the visual axis with a curved needle. He specifies the angle of insertion, the direction of the push, the aftercare. His students practiced on watermelons before operating on patients. Modern residents get cadavers. Marginal upgrade. Here's what you get when you simply do the math. 120 instruments for a civilization the departmental consensus places firmly in the pre-scientific era. Modern basic surgical kits contain around 40. Sushruta had 3 times that, with separate sets for obstetrics, fractures, urinary stones, and abdominal operations. 120 instruments don't appear from nothing. They imply generations of refinement, trial and error, thousands of patients. Nobody wakes up and invents obstetric forceps before breakfast. A transmission chain, teacher to student, technique to protocol, that we have no record of before Sushruta. He stands in the historical record like a monument with no foundation. 120 instruments, 300 procedures. But Sushruta wrote this down in 600 BC. What if the skill he codified was already ancient? What if surgery didn't begin with him, but long, long before? That question stops being academic the moment you see what turned up on Borneo. In 2020, a team led by Tim Maloney from Griffith University published a paper in Nature that quietly rewrote the history of surgery. Quietly, because nobody wanted to deal with the implications. In Liang Tabo Cave, deep in the limestone karst of East Kalimantan, they found a skeleton dated to 31,000 years ago. The left lower leg had been removed, cleanly, not crushed by a rock, not bitten off by a predator, not broken and rotted away. Amputated. The bone shows a clean, deliberate cut at the distal third of the tibia and fibula. No jagged edges, no splinters. A controlled separation. The stump healed. New bone formed over the cut surface. The individual recovered and walked the forest for 6 to 9 more years, in a tropical rainforest, without antibiotics, without sterile bandages, without sutures, without anything the settled science says should have been available 31,000 years ago. No pharmacy, no follow-up appointment, just a jungle and optimism. 31,000 years. That pushes surgery back past every known civilization, past agriculture, past pottery, past permanent settlement, past any written language, passed every date the syllabus assigns to the birth of medicine. Maloney's team confirmed it. This is the oldest known surgical amputation in the archaeological record. And it wasn't a hack job. Whoever did this understood anatomy. They knew where to cut. They understood infection control. They kept the patient alive in one of the most bacterially hostile environments on Earth. They understood wound management. The stump healed cleanly. Modern surgeons were performing this same procedure in the 18th century and losing patients to gangrene at horrifying rates. 2,000 years of textbooks, and they still couldn't keep a wound clean. Before Joseph Lister introduced antiseptic technique in the 1860s, post-amputation mortality in European hospitals ran as high as 46%. In a clean, staffed, supplied hospital, with chloroform, with trained nurses, with 2,000 years of accumulated anatomical knowledge since Galen, 12 centuries of European medical education, and they couldn't match what someone did in a cave, with a stone tool, in a jungle, 31,000 years earlier. And the Borneo case isn't unique. In 2024, researchers identified another prehistoric amputation, this one in France, dating to around 7,000 years ago. An elderly Neolithic farmer whose left forearm had been surgically removed. The cut sealed over. Recovery confirmed by bone regrowth. The technique was different from Borneo, but the result was the same. Apparently, caves make decent operating rooms. Survival. 31,000 years ago on Borneo, 7,000 years ago in France. The skill keeps surfacing, older each time, further apart each time. But the detail that makes it worse, trepanation wasn't local. It was everywhere. Trepanned skulls on 6 continents. The techniques vary, the tools vary. Nobody sent a memo. But in culture after culture, no contact, no shared language, no trade routes, surgeons cut into the same spot, the left parietal bone. Same location, same reasoning, independently. 6 continents, no contact, no shared language, and they all cut in the same spot. The course notes call it coincidence, parallel development of brain surgery. Sure, like 6 people independently inventing the submarine in their bathtubs, independently invented by 6 unconnected civilizations, without writing, without metalwork, with survival rates that embarrassed industrial-era hospitals. That word, coincidence, is doing a lot of heavy lifting. That's not coincidence. That's a pattern nobody wants to explain. Surgery saves you from trauma, but the wound itself can kill. Infection, sepsis, slow rot. Every ancient surgeon faced the same enemy, unless someone was already fighting bacteria. Sudan, the Nubian desert, heat that cracks stone. In the early 1980s, a team, including Deborah Martin, was analyzing bones from a burial site at Wadi Halfa, dating to between 350 and 550 AD. The bones belonged to ordinary people, farmers, laborers, families buried in simple graves, nothing unusual. Until Martin put the bone cross-sections under ultraviolet light. A yellow-green fluorescence appeared, bright, unmistakable, layered into the bone like tree rings. The signature was tetracycline, a modern antibiotic, the same class of drug that wouldn't be formally discovered until 1948, inside bones that were 1,500 years old. At first, the finding was dismissed. Contamination, they said, soil chemicals, lab error, the usual playbook when the data misbehaves. Then, A second study confirmed it, led by Mark Nelson at Paratech Pharmaceuticals. Then a third, by a different team at Emory University, using different methods. The tetracycline was in the bone matrix itself, deposited during life, not after burial. Layered in growth patterns that matched seasonal consumption. These people were consuming tetracycline regularly, in doses high enough to mark the bone, and they were doing it on a schedule. Nelson's team traced it to one source: beer. Ancient Nubian beer brewed with grain contaminated by Streptomyces bacteria, the same genus of organism that produces the tetracycline we use in pharmacies today. The Nubians weren't stumbling onto it randomly. Their brewing process, the specific grain storage, the specific fermentation temperature, the specific duration, produced tetracycline consistently. Not once, not by accident, over generations. Someone refined this recipe across centuries and passed it down. Fleming got a Nobel Prize for finding penicillin. The Nubians got a footnote. An antibiotic fights what's already inside the body. But what if the body has lost a piece entirely? No amount of tetracycline grows back a missing tooth. For that, you need something the body shouldn't accept, a foreign object, fused into living bone. Honduras. Sometime around 600 AD. A Maya individual dies and is buried in the Ulua Valley with 3 tooth-shaped pieces of shell fitted into the lower jaw where the incisors should be. The skull was discovered in 1931. For decades, researchers assumed the shells were placed after death, a funeral decoration. Cosmetic. Ritual, again. That word gets a workout in this field. Nobody looked twice. Then, in the 1970s, an Italian dental researcher named Amedeo Bobbio took a closer look. He ran X-rays, and what they showed stopped the debate cold. New bone had grown around the shell implants. Living bone. Compact bone tissue fused directly with the surface of the shell. The technical term is osseointegration, the same biological process that makes modern titanium dental implants work. A second team re-examined the skull with updated radiographic methods. Same result. The bone had fused. Osseointegration only happens in a living jaw. Blood supply must be active. Osteoblasts, bone-building cells, must migrate to the implant surface and lay down new tissue. The process takes weeks to months. The shells were implanted while the patient was alive. They functioned. The person ate with them, chewed with them, lived with them. And the bone accepted the material, nacre, mother of pearl, as though it belonged there. Nacre, it turns out, has a chemical composition remarkably close to human bone mineral. The Maya either knew this or discovered it through generations of trial. Modern dentistry achieved reliable osseointegration in the 1960s, with titanium, with sterile labs, with decades of metallurgical research and controlled clinical trials. The Maya did it with seashells, 1,200 years earlier. Not exactly a fair fight. Titanium versus nacre, and the seashell got there first. The bone accepted a seashell. But osseointegration replaces what's gone. It doesn't restore what the body still needs to do. What about function? What if the patient doesn't need a new tooth, but needs to walk? Egypt, roughly 950 BC, near the ancient city of Thebes, modern Luxor, a woman's mummy is found in a tomb associated with a priestly family. On her right foot, where the big toe should be, there is a device. Not gold, not jewels, wood. 2 pieces of wood, one carved to mimic the proximal phalanx, one the distal, connected by a leather hinge joint. The whole assembly is stitched together with linen thread and shaped to follow the anatomy of a human toe precisely. The wood is worn smooth on the bottom, from walking. The underside is stained and polished by years of pressure against stone and sand. The linen shows fraying at stress points. The leather shows creasing at the joint. This is the Cairo toe, not a burial ornament, not a symbolic attachment. A functional prosthetic designed to bear weight, flex at the joint, and restore a normal walking gait. The hinge allows dorsiflexion, the upward bend of the toe during the push-off phase of walking. Whoever built this understood gait mechanics, not in theory, in practice. Jacqueline Finch at the University of Manchester tested a replica on volunteers wearing ancient-style Egyptian sandals. The results, published in The Lancet, participants walked more naturally with the prosthetic than without it. Pressure distribution across the foot improved. The stride evened out. The design worked, not as a placeholder, but as a biomechanical solution. A second ancient Egyptian prosthetic, the Greville Chester toe, now in the British Museum, confirms this wasn't a one-off. Different tomb, different dynasty, same engineering principle. 3,000 years ago. No plastics, no polymers, no biomechanical modeling software, no gait analysis labs. Someone understood the mechanics of human locomotion well enough to build a working artificial toe, with carved wood, stitched leather, and linen thread. And they built it to last. Seashells in the jaw, carved wood on the foot, and the bone said thank you both times. But wood and shell are improvisation, materials that forgive mistakes. What happens when the problem demands precision metalwork inside a living skull? For that, you need a full surgical arsenal. And someone carved exactly that arsenal into a temple wall. Egypt again. The temple of Kom Ombo on the eastern bank of the Nile in Upper Egypt. Built during the Ptolemaic dynasty, roughly 180 to 47 BC. The temple is unusual, dedicated to two gods simultaneously, Sobek and Horus, with twin halls running in parallel. On one wall in the outer corridor, carved into the sandstone with exacting precision, there are 37 distinct objects: scalpels, bone saws, forceps, retractors, suction cups, hooks, scales for measuring dosages, sponges, shears, what appears to be a catheter, and what appears to be a birthing chair. Archaeologists who measured the carvings found that the proportions match functional surgical tools almost exactly. The curvature of the forceps, the angle of the scalpel blade, the ratio of handle to cutting edge. This isn't decoration. This is a technical manual, carved in stone on the wall of a temple dedicated in part to Horus, the god associated with healing and restoration. The departmental consensus calls them votive offerings, symbolic representations, images meant to please the gods. Nobody actually used them. That position has a problem. Several, actually. The Ebers Papyrus, dated to around 1550 BC, describes over 700 remedies and dozens of surgical procedures. The Edwin Smith Papyrus, even older, possibly copied from a text dating to 3000 BC, contains 48 case studies of trauma surgery, organized from head to toe, with diagnoses, treatments, and prognoses for each. Fractures, dislocations, wounds, tumors. Each case follows the same clinical format: examination, diagnosis, verdict. An ailment I will treat, an ailment I will contend with, or an ailment not to be treated. That third category, an ailment not to be treated, is the most revealing. It means the surgeon understood limits, knew when the damage was beyond repair. That's not ritual thinking, that's clinical judgment. These are not prayers, they are triage protocols. The instruments on the wall at Kom Ombo match descriptions in these papyri. The forceps match the forceps. The hooks match the hooks. Votive offerings that happen to be dimensionally accurate replicas of working surgical tools described in contemporary medical texts. Call that symbolic, if you can keep a straight face. And in the highlands of Peru, the other side of the planet, a different millennium, Inca surgeons were performing cranioplasty, not just opening the skull, closing it afterward with custom-fitted plates. In at least one documented case, confirmed by radiographic analysis, the plate was made of gold, hammered thin, annealed to increase flexibility, and shaped to the exact curvature of the individual patient's skull. The plate was not placed after death. The bone around it shows signs of healing, osteoblastic activity at the margins. The skull accepted the metal. Months of bone regrowth around the edges, not post-mortem placement, but a living body healing around gold. Gold cranioplasty, custom-fitted to the patient's anatomy, with post-operative survival confirmed by bone remodeling. No imaging technology, no general anesthetic, no sterile field, no surgical manual, at least none that survived. The surgeon had to measure the defect, hammer the gold to the right thickness, anneal it to prevent cracking, shape it to match a compound curve unique to that individual skull, and secure it in place while managing bleeding, swelling, and infection, all in a single procedure. Radiographic scans show bone regrowth sealing the gold into the skull over a period of months. The patients lived. Next, 8 bridges that physics says should snap under their own weight. Granite beams 21 meters long, 40 tons each, standing for millennia. No cranes, no mortar, no explanation.